Shalom, welcome to the Jewish View. My name is Rabbi Nachman Simon with the CHABAD House of DELMAR, together with my co-host Mark Ronich, who's been a reporter for 30 years in the Capital District.
Well, I'll take 30, but it's been more than 30, but that's fine. But
You'll look no more than 39.
Well, but in all those years, I've always said that teachers and nurses are the most underappreciated, overworked, underpaid members of our workforce. So I am so happy to have with us today a nurse, not just any nurse, but Judy Sheridan-Gonzalez. And she's the president of the New York State Nurses Association. And you work at Montefiore Medical Center in the Bronx. Mm-hmm. So welcome to the Jewish View. For me, this is so exciting to have a nurse on the program so we could talk about all the issues.
Do you have any medical issues over here?
No, I'm good.
Medical advice.
But I'm just so happy that, because of what I just said in the opening, is that you really can tell us what you're fighting for. And there are so many issues so you had a rally. And you more than one rally. I mean, you just keep rallying up here. I mean, all the years that I've been at the Capitol, it's another one issue after another. But what's on your legislative agenda that you were fighting for today?
Well, we're lobbying for the New York Health Bill. Assemblyman Gottfried's bill has been out here for about more than 20 years.
What does that say?
The New York Health Bill is a bill that basically would provide for what you would think about in terms of an expanded and improved Medicare for everybody. As people understand Medicare, this would make Medicare available for all age groups, and it would expand the services of Medicare. It would be publicly financed, but still with the ability to choose your providers, your hospitals, and so forth.
Isn't that a budget buster?
No, actually it's not. If you think about what costs money in healthcare, up to 32% of every dollar spent on healthcare goes through administrative and marketing fees for the private insurance companies. And certainly a lot of healthcare money is spent on pharmaceutical products that are way overpriced. With a single payer system, drugs would be way cheaper. And you wouldn't have to have all that administrative and marketing overview. Plus, a lot of what we do as health professionals now, but a lot of what has been done in the hospitals in the past, is spend time dealing with billing. If you have been to a provider in the past or been a patient in a hospital, you will notice that the providers who take care of you very often are looking at a computer and plugging information in. It's not just your diagnosis or what's wrong with you or what your complaints are. It's checklists to make sure that billing is done appropriately so insurance companies get their money so that the hospital gets their money. This would cut out a lot of that and allow us to actually care for our patients.
It's interesting. I never heard that argument before.
So you think all the electronic stuff and the computerization is somewhat of a hindrance, and it's somewhat of a help? But
the sell was that you would have a system in which we could have accurate information about patients that could follow them through the continuum. That's not the case because just like Apple doesn't interface with Samsung, we have these organizations that provide this kind of technology that don't interface. And so that is not necessarily the case.
But I have something called Follow My Health, that my doctor can post things, test results and stuff, and I could go on secure site.
Yes, if you have the one provider, yes. And that's a really good component of the technology. But that would just be a matter of, we have these systems really in place already where your lab work and your imaging work and the notes that your provider writes would be in a system. And allowing that system to be available to you would be a simple change. What the systems that they use now are much more focused on checklists and describing, at least I can speak as nurses. If I place an intravenous line in a patient or draw their blood or take their blood pressure or their temperature or do any kind of assessment of the patient or write a note, I now have to do that kind of process with checklists that go into a billing system immediately. If you have a complex complaint, it gets billed one way. If I do frequent vital signs, it's billing somewhere else. Any kind of medication, something else. How many IVs do I try? How many angiocasts do I have to use to put an IV in? You get billed for that. You don't personally get billed for that usually, but the insurance company.
How about Band-Aids? I mean, now you hear the extreme case that even Band-Aids cause because people,
I have not had to document putting a Band-Aid on a patient yet, but they may be coming. But a lot of our time is spent in doing that kind of clerical function.
Okay.
But the cost. So, what are we talking about cost? People think if they have a big employer or they have a union that maybe they don't pay for health care, but in fact they do. I'm not just talking about a copay or a premium or co-insurance or a deductible. Your health care insurance costs between $8,000 and $18,000, $20,000 a year, depending if you have family, where you live. So that's a cost. That gets eaten up by either the employer or through a union negotiations, or maybe, you know, partially by the employee. Mm-hmm. If you're paid a salary by your employer, they factor that into your salary. So that you are paying for it, because if you were instead given $18,000 more a year and say maybe paid $2,000 of that in a payroll deduction for Medicare for all, you're actually making money off the deal.
Now, the Nurses Association isn't just like a advocacy group. You're a union. You're one of the larger
Yeah, we're the largest union of registered nurses in the state of New York. We have 40,000 members.
40,000 members. So it's, you know, it's not like, you know, if people think of CSEA and they think of SEIU and they think of a lot of other places that have, you know, sort of union attached to all those, I guess, CSEA, Civil Service Employees Association. So I guess that answers my question right there. But, you know, Public Employee Federation. Right. So I guess, you know, you're like the teachers have the union, United Federation of Teachers, or New York State United Teachers. This is the nurses version.
Well, we're a union, but we're a professional association. We were initially a professional association, so we're kind of both. But our view is that we're a social justice organization. We fight for social justice. As nurses, it's in our DNA to be advocates for our patients and our communities, and that's how we've gotten involved with a lot of these issues.
So you have are there other nurses with other unions? Are you split, or do you have...
There are other nurses in other unions who unite with us around many of the issues that are important.
And I was going to say that, do you have non-nurses in the State Nurses Association?
In the State Nurses Association, because of the way labor law was configured probably about 20 years ago, we've absorbed some units that consist of health professionals as well, but it's a small group of our members. But we...
You know, on the idea of nurses, I always, you know, sometimes you have on the TV, we need more nurses going to nursing school. And then I had a few, you know, of course I do mostly with Jewish people, with Jewish young women, and they say, well, they're nurses, we'll get it, you know, I don't have a job. So you don't have a job. They're screaming they need nurses. You're a nurse. It's, well, you need experience, or no one's going to hire you.
It's a false dichotomy that gets created. I mean, one of our other issues is, of course, fighting for safe staffing. You know, the hospitals know that nurses are going to miss their lunch, miss their break, not go to the bathroom, stay late, do the work. They do very well that way. They don't have to hire as many people because we're going to take care of our patients. But we're grossly understaffed, and there's a definite need for more nurses. But some of the hospitals say the budget doesn't allow us to hire more nurses, or they spend their money on waterfalls and all these other things that they put up in the hospital.
Aesthetics.
Yeah. We don't think the patients.
Soothing.
Yeah, I think a patient would much rather get excellent care from a nurse.
I understand. No, when Albany Med redid their facility, they did something like a garden outside to ease the pain of and suffering that you see.
But that speaks to this whole concept of healthcare. It shouldn't be a consumer business issue. Healthcare is, we believe, a human right. Yeah. And I think certainly many of the religions teach. I know I was looking up Talmud stuff, you know, about charity and, you know, what's really important as to take care of our community. Healthcare is a human right. Hospitals are hospitals. Clinics are clinics. They're not hotels. It's not about customer service. It's about taking care of people. There was a couple of years ago, they were trying to tell us we need to read script. Instead of talking to a patient, we're supposed to read a script. Hello, my name is Judy. I'll be taking care of you today. I hope that you will have a good experience here. I mean,
written by a lawyer.
It's ridiculous. I mean, we connect with patients in very, very intimate ways.
Yes, you do.
We do it in our own particular way.
That's right.
That is something that is very important to us, because nursing is not just a science, it's an art. And it is a field of compassion. But in our interaction with people, we're doing assessments, we're evaluating what the patient needs. We don't really have the opportunity to do that right now. Partially because of staffing, certainly, but also because of the way the health system is configured.
Yeah, I'm going to get to the staffing part in a minute, but do you feel like you're being more of a doctor these days? Like the nurses are subsuming some of the roles that it used to be a doctor writing prescriptions, whatever?
Well, we have nurse practitioners certainly that function as primary care providers or specialty providers, but bedside nurses also are taking care of patients that are way sicker than they ever were. I mean, things that used to cause patients of 2-week hospitalizations are done overnight now or on the same day. So the patients we take care of are very sick. Because they're very sick, you have to monitor the patient much more carefully and have a way higher level of knowledge about subtle changes in condition that could be the difference between life and death.
Well, even on the positive side of life, I mean, it used to be when a woman gave birth, there would be, a week and a half you'd spend in the hospital. Now it's 48 hours, 24 hours, whatever it might be.
Right. Because
I don't speak from personal experience. Rabbi Simon has 13 children, so
it's 48 hours, and that's because the New York State Assembly, the Capitol here, mandated the women. Because I know them, I mean, now it's been the years past, but there was a lot of women that got together and they wanted to kick them out after 24 hours. In some states they do. So they made a law up here in the Capitol that they at least got to give them 48 hours. And the women of the Assembly.
So therefore your care for that patient is not based on just keeping the patient alive or preventing a critical negative outcome. It has to do with interaction and teaching and sharing and helping a person walk through a very tragic or a very important part of their life. And as nurses, that's our role. But we're not able to enjoy that privilege, and the patients aren't able to enjoy it as well either because we're very rushed. But the other thing that we do is so much of our time is spent dealing with this outrageous, private insurance situation. Or you're in a hospital where many of your patients are on Medicaid, and the reimbursement is so low, there's a lot of clusters together, or people are waiting longer. Or you have patients on Medicare who don't have enough, they don't have maybe Part B, or maybe they don't have another Medigap kind of insurance, so they're not wanting to get treatments because they're not sure if their insurance covers it. I mean, we see patients are neglected. Patients are suffering because of the way the healthcare system is right now. And given what's going on in the federal government, we're horrified to think of what it could be.
They always say that, like in other countries, it's better. I mean, I don't know, but in Canada, because I have one son living in Canada, my grandson is something, it's not important, but 5 years later he got an appointment. So it goes the other way. I mean, on one hand they say, everybody has health care in these other countries, but if you have to wait 5 years to get treated.
People wait a really long time here too for many things. I think that it really depends on the situation. You can hear one anecdote, but in general, if you tell Canadians you want to take away their healthcare system, there'll be a revolution in Canada and in England and in Australia and in France and anywhere they have a single payer type of system, because everybody's guaranteed health care. They don't have to deal with bills and co-pays and all this other stuff. I work in an emergency room where typically you would have a patient coming in there for primary care because it took so long to get a primary care appointment. Under a single payer system, primary care would be much easier to access because that would be the front line where people would get care.
So is this what they might call socialized medicine?
Well, actually, this would not be socialized medicine. This would be a system in which it's just it's a form of an expanded Medicare with more provision, more coverage, and including everybody.
Because if anyone in the audience, who's
socialized
watching
medicine,
would think that, I just
the government would pay the salaries. Everybody would be working for a national health service, like sort of what they have more in England. Now, this would be just a different way of billing, and it would be the government would be the payer. And then you could negotiate rates, certainly with drug companies, which is a big, talk about cost in the long run. If you're able to have a single payer system, your negotiations with these drug companies would be altered dramatically.
When you talk about staffing ratios, is there still a common practice that hospitals would rather bring someone in, like they have these groups, bring someone in from the outside, as opposed to having a nurse on staff where they have to pay health benefits to the nurse?
Yeah,
isn't that ironic that
we're
hospitals don't want to pay health benefits to the
We find it very ironic. We are finding many more nurses coming in as agency nurses, contracted nurses, because then there's no obligation of the hospital to keep them on board. Right. So we said, well, if there's a crisis or a hurricane or something, and you don't want to hire people who you're going to have to let go because there's no need for them, we understand that. But when you have them constantly bringing people in, year out, all the time, it seems to me there's a need to have permanent staff. And of course, permanent staff has a commitment to the community, more loyalty to the institution and the population.
Look, I know, St. Peter's Hospital here in Albany, there's a real rotation. You don't know, you don't have a chance to develop a rapport with that nurse. You don't know who's coming in next.
Right.
And it used to be, there was a time when, Saturday mornings, the woman, the same name would be written up on the whiteboard or, in front of the bed. So you knew who that person was in that next shift or whatever, now you just see a different, just all these different names.
Right.
It just doesn't make you feel like there's a whole lot of consistency.
We think with the single payer system, such as illustrated in the New York Health Bill, which you should probably research much more because there's so much to know about it.
Well, too much for a half hour.
Too much for a half hour. That's why I'm not going to get into the details of the bill, but we think that with that kind of a system, a lot of things, which there'd be a domino effect in how care is delivered, how care is received, and what happens to patients. Because it'd be much more prevention and initial treatment.
But how, it sounds like a good idea, and I'm not an expert, I'm a rabbi, I'm not a health professional. But on the other hand, just practically, I know you're working hard, but you think that it's going to get passed? We have a lot of politicians come in, and it's like, oh, I have this thing, we've been here for years.
We think we're just one senator away.
Really?
Right now.
Well, that's pretty good then.
Yeah.
Because, sometimes people come with ideas. I have an idea, and it could sit there maybe almost for never. Who knows what the future will bring, but, for years and years, they're working on they have a new, nice concept, and it's not going on.
This is about the sanctity of life. And the problem is that people don't understand the nature of the bill because the insurance lobby and the pharmaceutical lobby is very powerful, and they advertise things, and people are misinformed about what would be the initial cost and what would be the inevitable consequence. We met with in Senator Felder's office today, and because he has not signed on yet, and there was a woman from Israel who said, we have socialized medicine in Israel, or a similar system. I think it was even more that the government pays actually the physicians. And she said, it's fantastic. She said that we would never think of having anything else. And then she also talked about Jewish tradition and charity and stock.
She was with you in a lobby?
She was lobbying. She was lobbying.
Yeah. Oh, she was lobbying.
Yeah, she was lobbying.
Okay.
And promoting that kind of a system, which basically every other developed country in the world has.
Did you meet with the senator himself or with Darlene?
It was his staffer.
Darlene?
It was a young man.
Young man, okay.
And we're trying to say, people need to understand the dynamics of the bill to understand what it could do.
Yeah.
The other thing we think is that in our society right now, in this country, there's a lot of polarization and there's a lot of animosity among people and a lot of divisions. And we're thinking that in New York's not so much like that. We want, a lot of people are feeling that New York can be a real lead, and California as well, in a different kind of a kinder, gentler society. And this is a kinder, gentler bill that would help to create that.
Well, now you're talking about staffing, and I think later on April 25th, maybe,
we'll be here for the staffing.
You have to
come back again.
You're going to be talking about the ratios. Now, I know this is nowhere near a comparison, but I know when you go into a restaurant, they have a waitress for a certain number of tables because if you have a waitress spread out too much, no one's going to get the table service that they need. Right. Same thing with nurses. If you're spread out over too many patients, no one's going to get the care that they need.
Well, you might get pancakes instead of eggs in a restaurant. In a hospital, you might be waiting 2 hours for your pain medication. I think there's a big difference
Or
there.
you don't want to get the wrong medication.
Yeah, we're
that's
very careful about that. But there's mistakes are made when you're understaffed.
Yeah.
Like I said, the big issue is that our patients are very sick now, and they require incredible amounts of attention and support. Yeah. And many patients are on multiple medications, not just one.
When my father was ailing and he had cancer, I stayed there with him because I knew how understaffed St. Peter's was with their nurses. So when he needed something like water or he needed a pain medicine, I went out and I found the nurse, or I got the water myself, or I did whatever I could do to help the nursing staff.
It's really changed. I remember I started in nursing and we did everything. The nurses or the attendants or the nurses' aides took care of our patients. The families didn't have to do anything. Now that's been shifted onto the family. Even people who go home. People used to go home, the family would turn on the television, read to them, give them a hot compress. Now they're suctioning their tracheotomies. It's ridiculous what's been put on families because there's not a desire for nurses to take, that's a staffing issue. That's also how healthcare is configured. Nobody wants to pay for what care costs.
I remember hearing people screaming from their beds to help them because they thought they saw me walking up and down the halls to deal with all these things. They really thought I worked there. And I felt so badly because I couldn't get into their rooms or into their lives. And, I just had, my dad was my only patient.
Well, there are hospitals, and quite a few of them have VIP floors or VIP situations where you don't have to do that. So this is not just about quality of healthcare, it's about equality of healthcare.
Yes.
If you're not incredibly wealthy, you're subject to whatever is available for you. But there are many hospitals that exist that have areas in which patients are getting a whole other, some of them they call them amenities floors, where they get a lobster dinner and all kinds of things.
Well, not if it's a, Montefiore has...
Not Montefiore.
No. They wouldn't have lobster at
No, no lobster at Montefiore.
It's the Bronx, is this still a Jewish-run hospital? I don't know, because a
I
lot
don't
of
know
times
what
I know...
Jewish-run means.
Well, the Federation, Jewish Federation
I'm sure they get
Chicago,
donations from Jewish
That's what I'm
Federation,
saying.
yeah.
I mean, Ron, you're right, I guess.
But our population is many of our patients are poor patients who live in the area.
Yeah.
Many patients are immigrants, speak other languages.
Yeah, but for example, Maimonides Medical Center, which sounds like Montefiore from someone who doesn't know.
That's in Mr. Felder's district.
At Maimonides Medical Center, they have what's called a Shabbos elevator.
Yes.
And
they have it at Mount Sinai as well.
Okay,
and in our other campus at Einstein,
They have.
The division I work in does not have that.
Now, Maimonides also has only kosher food now.
Right.
So I didn't know if Montefiore...
No, in the other campus they do. In our campus they don't. It depends on the patient population.
That's true, and that's why I was asking you about that, because if you're Jewish, you go to which campus if you want that.
Well, we have kosher food at all campuses, though. We have access to kosher food. We have sometimes a lot of patients who get kosher diets. You have a choice there.
What's the silliest thing that you've been asked?
Silly?
Silliest thing as a nurse that you've been asked?
By a patient?
Yeah.
Oh, when you want to put an IV in a patient, they say, have you ever done this before? And I always say, no, the last time they only lost their arm, don't worry. Like to try to make them laugh. People are nervous of things like that. Or they come up with their phone, they say, what do you, there's a lot of dilettantes now, what is this, whatever this is, or whatever that is, or they come in and they bring you a picture of what their vomit looked like and stuff like that. There's weird things with these internet now that people are doing. It's kind of strange. It's created a different dynamic.
Everybody thinks they're a doctor.
Well, we are actually, in my entire community and family and friends, they call me, and everything I tell them, they say, I went to the doctor and it was exactly what you said. I should just call you. With experience, you learn a lot.
You do, yes, absolutely.
And our knowledge base is broad now. It has to be.
What is the ratio that you feel should be patient to nurse ratio?
Well, there, of course, are different units with different levels of acuity of our patients. So in a typical unit where people might have asthma or pneumonia, we think, 4 patients is what we should be taking care of per nurse. 4 to 1. In some hospitals, it's way higher. It's pretty dangerous. Plus, remember, if we want to take a break, somebody has to cover the patients. Exactly. So our staffing bill provides for somebody to cover the patients, because otherwise, in the emergency room where I work, I could be taking care of 7, 8, 9, 10 patients. And if I go to lunch, somebody's taking care of 20 patients. Which is, when you should be taking care of 4.
So then you say, what's lunch?
Right. That's why a lot of us have a problem with eating.
And you remain so thin, healthy.
Well, because you're not eating. But no, that's a big problem. But again, it has to do with them saying we don't have the funds, and that's why we think if we had a different system that was governed in a different way, paid for in a different mechanism, then people talked about all these jobs that would be lost without insurance, why the insurance industry started closing down. Then we could train people and actually hire them to work in the hospital. That would be a wonderful fit, so we can get actually the help we need. So you wouldn't have to take care of your parent to the extent, or your parents' neighbors, or that you wouldn't have to do all the things that you have to do. There's definitely a need for more caregivers, and we think that for employment, it's much better to have people taking care of patients than working on billing.
No, absolutely, and I think that's why the computers help with the billing, because then you don't have to figure it out later, or you don't have to have a whole bunch of other staff, administrative staff, figuring it out later. I mean, it used to be the billing took a lot longer than it
Well, they're
does
still
now.
doing billing because they have to correct, recorrect, argue with insurance companies, re-argue, make
I
a case,
understand it's
appeal.
not perfect, but it's less timely. It's more timely. I mean,
There are so many people spent dealing with insurance companies right now. If you look
Really?
at the, sure, absolutely.
Okay.
It's just so much, it's inflationary.
So besides single payer and besides the ratio, what else is on your wish list? And
Well, safety net funding, not cutting Medicaid. You know, we want to save our safety net hospitals, keep our public health system intact.
okay, so what is safety net funding?
Safety net funding, there is a bill, both houses passed the bill, the governor hasn't signed it. You know, there's a lot of budget concerns right now,
Okay.
which would provide funds to ensure that the poorest populations and the populations that are most vulnerable, many of these hospitals are upstate hospitals,
Right.
not just down in New York City,
Right.
would continue to receive the appropriate funding to continue to care for their patients.
So that's safety net funding.
Yeah, yeah.
Okay, so
But also other social justice issues, paid family leave, the fight for 15, minimum wage, we've
Okay.
been involved in all those issues.
Why is that? I mean, just because you're a nurse, I mean, it seems like I know those are big issues nowadays, but it's just like you got to pick your battles. I mean, it doesn't seem like
Well, we
that's in
support the
nurses.
issues that sustain health, and if people don't make enough money to buy food and provide for appropriate housing and a quality of life for their families, they're going to get sick.
So just let me ask you one quick question. I don't know if it's a quick answer, but it's a quick question. Is that the billing of the patient care and funding of patient care, if you don't have insurance, are you saying that the hospital won't triage your case as
The emergency
quickly?
room, because of EMTALA laws, EMTALA laws, we cannot ever, no hospital, I know in New York State and pretty much in most of the country, except people get around this, cannot refuse care.
Right, you cannot refuse care.
But
right. That's why I
You
said
can be
triage
refused
it.
care in clinics, you can refuse
Okay.
care in any other kind of setting,
but
which
when
is
you-
why emergency rooms are so overburdened right
Well, when
now.
you have these larger hospitals,
Mm-hmm.
they have foundations that raise money, 501c3s, and
Right.
they raise money, not just to build the building, but also to help out the indigent.
I think the way in which that money gets managed varies. Some people donate their money for specific things, for
Right.
research, for cancer care, for
Right,
various
to name
things.
a room after them. whatever.
Exactly.
Yeah.
So it's very different. But charity care is not funded well by the endowments at all. It really has to come from the government. So the government is already paying a lot of money for care for people.
Well, I also know from experience that if you get a bill from a hospital and you write, I can't afford to pay this, they give you a reduction, and they ask you, what can you afford, and they give you time to pay out.
Right.
So there's something.
But people are still being bankrupted by healthcare needs.
Well, you just
or
pay
not
it for a
getting-
lifetime. That's all.
Or not getting what they need at a certain time, refusing chemo, refusing surgery, refusing other things. But our emergency rooms are just totally overburdened by people who can't get care in any other way.
Yeah.
Or they wait too long because they're not sure that they'll get coverage, or they haven't gotten the appropriate care initially. So, we would like to have a healthcare system where people are actually taken care of.
No, that would be great, but I'm just saying as a practicality right now, I was just bringing that up as a point, that there are other venues and other ways of working the system for yourself, as a patient.
Yeah, I still think people are not on the winning side of that team.
Okay, all right. But I wanted to bring it up and have it as part of our discussion.
Okay.
Okay. Well, thank you very much.
Mark, we're out of time. It was really important that we had the discussion because healthcare is so important. It's not like building a baseball stadium. I mean,
Right.
it's something that everybody's, and if you need it, you always say a blessing. I'm the rabbi. You shouldn't need to have a nurse or a doctor, but when you need it, you need it. I mean, there's no
right.
joke. So therefore, you're doing God's work and helping
Thank you.
patients to do the right thing, getting the help they need, and should continue doing it. And you should also have good health.
That's
Thank you
right.
so much.
Good. Best of health and success.
All right, thank you.